I'm talking to you today about a system and how it saves a life. Ambulance Victoria has been in the life-saving business for 135 years, and we think we do it pretty well. We were one of the first ambulance services in the world to roll out a mobile coronary care unit in the early 70s with our paramedics. We rolled out defibrillation to our workforce in the late 80s, to our volunteers in the early 90s. We had great case studies saying we're doing well. But the problem with that sometimes is you drink your own bathwater. In the late 90s, our medical director, Professor Steve Bernard, did a pivotal study that said despite what we thought we were doing, we were seeing less than 25% of people having CPR in the community. We were seeing outcomes of only 3%. This is only 10 people going home for cardiac arrest in the city of Melbourne over a 6-month period. Something wasn't right. We then looked at the MCG with Jeff Wasserthiel and his work, and what we were seeing there is we're seeing outcomes of around 71% of people going home following cardiac arrest. That was a system of care operating the MCG. Ambulance Victoria wasn't operating one. We had to change the way we thought about how we did business. The most important thing is to understand what we were doing. So a cardiac arrest registry that allows us to understand from the time a cardiac arrest occurs, what occurred at the scene, what happened within what they were like at hospital, hospital discharge, and their 12-month quality of life follow-up. We know everything there is to know with 100,000 cases now in this registry. We work to improve community CPR. We put in place an innovative 4 steps for life now called Call, Push, Shock. We've dropped a step, making it easier. We work with our dispatchers and call takers to make sure that they were actually coaching effectively for people to perform CPR in a cardiac arrest. We improved defibrillation in the community with public access defibrillation in locations of high throughput, and rolled out a co-responder program with our fire services. We also used the data coming out of our registry with our amazing researchers and clinicians to actually drive change and improvement. Some of that was including where we take people, because taking them to the nearest hospital wasn't necessarily going to improve their outcomes. So how are we doing today? Well, if you look back to where we were, 23% of CPR back in 1998. Today, if you look at bystander witnessed arrest, 46%, up now to 63% in the community. And if you suffer a cardiac arrest in Victoria now, for all-cause cardiac arrest, you're twice as likely to survive than you would have back in 2002-3. And importantly, you are also, in a shockable rhythm, almost 4 times more likely to survive cardiac arrest. And importantly, they're not going to nursing homes. These are people who are going home to their families. 85% of people are returning home. Around 13% are going to rehabilitation at post-discharge. They are going back to the work they were doing before. 71% of people are back at work who suffered cardiac arrest, are back at work, with the majority of those doing the job they were doing previously. And their quality of life, and they're as happy, and I'm pretty happy too if you just had me from a cardiac arrest, they're happy as anyone else in the community who had not suffered a cardiac arrest. So what have we learnt along the way with our work at Ambulance Victoria? Well, first of all, saving lives is a team effort. It is not about doing it all yourself. That's where we went wrong at the beginning. We were trying to do it all ourselves. It is about working with others. It's about collaborating with those at the point of call to make sure they're offering as best care they can in supportive CPR coaching. Working with the community to be able to respond. The community want to help, so how do we work with them to ensure that they're actually able to do the things that they expect to do? And importantly, also working with other agencies, fire services. The most powerful thing we've done over the last 20 years is to work with our fire service to have them respond to cardiac arrest, and it's making a difference. The other key one for me is if you don't measure it, you can't manage it. You sit there, again, I mentioned before, drinking your own bathwater. You start getting very comfortable that we're doing this great work. You have these great case studies. The reality is that if you don't measure what you're doing, then how can you improve it? The mantra coming out of Seattle is about measure and improve, and that is what all ambulance services and EMS services need to be focused on. The other key one for us is very much around benchmarking. So again, looking at how you're going, look over the fence, and look over the fence comparing apples and apples. I see lots of studies coming out about how good cardiac arrest outcomes are. At the end of the day, if it hasn't got Utstein somewhere within it, then I take it with a bit of a grain of salt. But looking at Utstein in Ambulance Victoria, as you can see there, we're now against the Utsin template for shockable rhythms, for the state of Victoria, we're at 37% survival to hospital discharge. In Melbourne, we're at 41%, a 3% improvement on the year prior. And we're doing pretty well when you compare us to other services that are reporting against the template. The other big one for us is that accountability is the key. So I'm held accountable by my board to improve cardiac arrest outcome. It's one of my KPIs. It is not just about response times, it's not about just things like that, it is about actually improving outcomes. So I am accountable for it, my staff are accountable for it. Saving lives in cardiac arrest is part of the DNA of our organisation. And we're also accountable to the community. So importantly, we're actually out there with the community every year, telling them how we're going, publishing our annual report on cardiac arrest outcomes and letting them see how we're tracking. At the end of the day, we're there to meet their needs in the community. So where do we go to from here? So my little 3-year-old daughter absolutely loves Finding Nemo. And Dory, I think, has a mantra for life that fits in with a lot of things I talk about, and cardiac arrest improvement is one of them. At the end of the day, Dory talks about just keep swimming. And just keep swimming is very much about cardiac arrest improvement. You can't rest on your laurels. You can't just stop there and say, look how good we are. There is always more to do, and there's always someone who is doing better. So how can we improve? For us, it's very much focusing on this principle of early defibrillation and CPR for patients in shockable rhythms. So we're out there looking every day at how we can improve early access to defibrillation in the community. We know that people who are resuscitated in the community, who succumb to cardiac arrest in the community, are most likely to be resuscitated because there's people around them who know what to do. We know that if you're in a cardiac arrest and defibrillated by the community, you have a 72% chance of getting to hospital alive and 64% chance of going home in Victoria. Those are very similar rates to if you arrest in front of one of our paramedics in the back of their ambulance or at home. So for us, it's about crowdsourcing. How do we take the community on the journey with us? No longer fortuitously just coming across a cardiac arrest, but actually doing something about it. And that, for us, is around using Good SAM. This is Andrew Crellin, an emergency physician. Andrew's a great example of someone who's a beneficiary of the system of care that we offer in Victoria. And Petra's the future, a cardiac arrest survivor who's had a heart transplant as a result of eCPR being provided at the Alfred Hospital. These are great examples of 379 Victorians whose lives have been saved last year through a system of care we're operating in our state. Thank you.
So, reporting the news live, Smackforce News at the heli base. So just some difficult questions from myself, working in a low-resource constrained environment. From what I see, cardiac arrest is 1% or less of your patient workload. How do you justify putting all of your focus and attention into researching and improving cardiac arrest care when so many other patients need your help?
Yeah, great question. And there's some good evidence out there to suggest that if you are focusing on improving your system of care for cardiac arrest, you can do it for other things such as trauma, stroke care. It actually gets into your DNA of your organisation, this principle of improvement, never resting on your laurels. Doing well in cardiac arrest is a pretty easy measure to show you're either dead or alive, and to continually improve the number of people who are alive and doing well in the community gets the momentum in the organisation to say we can do better in every part of our business.
Let's see if there's any other difficult questions from our viewers back at home. All right, so you've seen a lot of significant improvements over the past decade. What do you think are the next big things that are going to happen?
So for us, I think it's twofold. One is about better improving access to community resuscitation using Good SAM, as I mentioned before. And we're rolling out Good SAM now. We've got about 5,000 paramedics, health professionals and trusted responders on there. The next couple of years for us, well, later this year, we'll be rolling out Good SAM to the whole Victorian community. So how do you get all millions of Victorians actually on Good SAM who are trained in CPR able to respond? That'll be the big game changer. The other one, I showed Petra before. Petra's an example of the next cutting edge using eCPR, mechanical CPR to hospital, eCPR, on a left ventricular assist device in ICU for 2 months, had a heart transplant, is going home. She would never have even made it to hospital a few years ago.
All right, and then just lastly for my viewership back home, what are the significant roadblocks that you were met with in your journey?
And I think this is an issue for a lot of ambulance and EMS services. You get very complacent and you actually, I said it before, you drink your own bathwater. You think, how great are we? And if you're not prepared to look at yourself outside, you're not prepared to challenge that you can do better, the risk is you will just keep doing more and more of the same. So for me, it's about being prepared to actually be honest about how you're performing and to look at how you can continue to improve.
Perfect. Thank you. Kat Evans, SmackForce News, Victoria.
Thank you very much.